It's the boldest enhancement to health care coverage since Medicare was introduced. A special advisory panel is demanding a Pharmacare plan for all. Comprehensive coverage spanning the country with a hefty sticker price of $15.7 billion by the time it's fully phased in 2027. Here is how the federal health minister reacted.
I want to be clear that as a government, we are committed to making sure that all Canadians have access to a national pharmacare program, and I'm truly committed to making sure that we work in close collaboration with provinces and territories because they are key to making this a reality.
Well, the official opposition leader, well, he wasn't impressed.
They've been making this promise since 1997, and in the dying days of a scandal-plagued government, they're trying to, bring this forward. What people know is that this proposal was designed by a member of Kathleen Wynne's failed government. And Justin Trudeau hired someone from a disastrous provincial Liberal government that spent Ontario into the ground with unsustainable rates of spending growth that left Ontario in a fiscal situation that's very, very difficult. They've now hired that person to design a federal program. You'll excuse me if I have zero confidence in their ability to manage this or to introduce this.
All right, well, this advisory panel was chaired by former Ontario Health Minister Eric Hoskins. He joins me in the studio. Dr. Hoskins, Andrew Scheer thinks this was a fix was in and that you're just putting in a Cadillac kind of program. Why was it necessary, in your view, for taxpayers to shoulder the full cost of a full and comprehensive program rather than just fill in the blanks where people don't have private coverage or can't afford it?
Well, it's nice to see you again, Don. And first of all, Canada is the only country in the world that has universal health care but doesn't have universal or national pharmacare. So we're unique in that sense. We spent the past year crisscrossing the country speaking to thousands of Canadians, and what we heard from them is that not only can we do better, we have to do better with regards to access to prescribed medications, but they believe that access should be based on need and not ability to pay. We also know from the model that we recommended, Universal Single Payer Public, that has the greatest opportunity to reap enormous savings by lower costs of prescription drugs. We've seen that in other parts of the world. We can have that here in Canada as well.
Buying, basically, right?
Well, we pay the third highest prices in the world after United States and Switzerland on a per capita basis. We can do better and certainly reduce those prices.
See, but the way I read the Constitution, healthcare is a provincial responsibility to deliver. So what's going to have to be done at the federal level to transfer that responsibility to the provinces? How do you deal with that?
Well, currently, and you're right, the provinces have the responsibility and the authority and the territories to deliver their drug programs, the public drug programs. That's why we spent a great amount of time over the past year talking with provinces and territories, officials as well as politicians, government members, and we're met by uniform, I would say, enthusiasm that we need to address this challenge, that drug programs are becoming more and more unsustainable because of the high cost of drugs. Jurisdictions are wanting to provide better coverage to their citizens, their residents. So there was, and in fact, the Council of Federation last year came out and spoke specifically about Pharmacare and what they hope to see in it. So we believe, again, through this model that we've created one that would be an opt-in model, just like Medicare was in the 60s, where there would be a financial transfer in exchange for provinces and territories agreeing to certain fundamental principles, which would be essentially the similar principles or the same principles that we see in the Canada Health Act for universal health care.
Right, and assumably if you didn't do it, there'd be penalties attached to provinces that didn't or whatever.
Well, I think we have a unique opportunity to do this differently and in a way where the funding mechanism gives confidence to the provinces and territories that it will be sustainable. We're asking the federal government to step in for the provinces and territories to continue doing the funding that they are, but for the federal government to pay for that increased access and better affordability. So it's a model which is used in other parts of the world. It really does speak to that issue of equity and fairness and accessibility, which is a real challenge in Canada. About 7.5 million Canadians today are struggling to pay for the medicines that are prescribed to them.
And it's going to be, I see it, the way I understand it, you're going to do sort of, it's almost like a two-phase system. You start off by essential drugs,
right,
and then as the system sort of matures, you expand it to include eventually everything. What's that going to look like in 2022, and what's it going to look like in 2027?
So it does take time, partly because we are a federation and partly for the reasons we just talked about, the constitutional responsibility. So there's legislation that needs to be passed. There's negotiations, of course, with provinces and territories, creation of a Canadian drug agency to do the heavy lifting of building a list of drugs and making them available, negotiating with manufacturers. And so by January 1st, 2022, we're recommending that essential medicines, which are medicines for not just, but mainly for sort of the diseases and illnesses that are more common to Canadians. It represents about half of all the prescriptions that are prescribed annually in Canada, that we start with that and then aggressively and consistently build up until we've covered no later than January 1st, 2027, the full list of drugs where there's clinical evidence that they're effective, there's good value for money, and make that available to all Canadians.
It is a big price tag, $3.5 billion for the first sticker price, $15 for more. You've been a doctor. You see that there's a shortage of healthcare services of the more acute variety. People are getting treated in hallways or even dying in hallways. There's a shortage of doctors and nurses for acute care. Is this a better use of tax dollars, because there's a limited pool, than trying to get the actual acute healthcare system under control?
I believe it is. So not only will this model, it's estimated that in its first year, it will save $5 billion. So we're already spending a tremendous amount of money on prescription drugs. Last year, $34 billion. It'll probably rise to about $55 billion by 2027. We can flatten that cost curve and bring it down so it's more affordable. And at the same time, we can actually put more money in the pockets of Canadians. We estimate that with this model, the average Canadian family or household will save $350 a year. Employers will save about $750 per employee. So there's tremendous benefits of doing this. And the advantage of this model over fill the gaps is it's really challenging to even identify the gaps. It's not simply people who are uninsured. There's about 1 in 5 Canadians are either uninsured or underinsured. They may have public or private insurance, but it's not adequate. And we're seeing that those systems are becoming even less affordable for Canadians.
Okay. All right. Eric Hoskins, thanks for coming in. I appreciate this.
Thanks, Don. Appreciate it.
All right.